Okay, so I just want to take this a few minutes just to share my experience. Right. So just as a background, I think everywhere around the world, but in fact in Malaysia, in this region, we have a very high peripheral vascular disease in our country. This mainly because of diabetes. Our diabetes rate is quite high. In fact, in my center is actually located in the heart of Malaysia, in the Klang Valley. We do have a lot of beds, and actually I'm the only vascular surgeon here. So, but with the help of my colleagues from cardiologists and also from interventional radiologists, we do around 500 cases per year with about 1 to 2 cases of lower limbs. We do update ourselves according to the global vascular guideline, and in recent years, I think we see more and more endovascular devices to help us to treat this condition, and we do have limitation as well. From this, as you can see here, if we have a lot of recourse, we can use stents, ISR, we can use DES or DCB or covered stent. In fact, in calcium, a lot of people suggest atherectomy, but because of the cost, some cases they can't of scoring balloon and even cutting balloon. Okay, and we have issues with mechanical force and things like that. In the market now, I think at the moment now in my country, worldwide we have angioscope, NES from B Brown, Scoreflex, chocolate balloon, basket track. Okay. In Malaysia, we don't really have this. We have Scoreflex. We don't have the others. And recently we have a Tri-Wedge, hence the presentation today. This scoring balloon has been around for quite a while. It started with the coronary region where, from this paper, they did the PCI, using the NES balloon. It's a similar configuration to Tri-Wedge. However, as you can see here, it's triangulated scoring mechanism, but they use a polymer rather than the nitinol wires. Okay, and it actually, they concluded the study as a high procedural success rate and low TLF rates in de novo lesion. How about peripheral? So in 2020, Kozunuri et al. Has evaluated the impact of scoring balloon for peripheral fempop lesion, and according to their studies, based on almost 400 patients, they concluded scoring balloons also effective in restoring acute ligament gain, and also is associated with a better primary patency at 18 months. And there's another study, this is Maria Conlech et al. In this study is comparing angioscope versus POBA. So in this study, it's actually a negative study. According to the study, it mentioned that angioscope actually a safe scoring balloon to be used in the peripheral region. However, it did not significantly improve vessel patency compared to just a standalone treatment. And this is what this paper. To the product, Tri-Wedge. So I think I don't need to mention this too much because it's been introduced by Leo just now. But just mention the indication actually extend to peripheral region in the iliac, femoral, iliofemoral. So even in the iliac, we can use it, and even renal arteries. Okay. And as you can see here, the balloon size actually extend to 8 mm. So we can actually use it in the iliac system and down to 3 mm, and we can actually use it to the tibial as well. And the markers, so these are the markers that you can look for on the fluoroscopy. And as mentioned just now, I think because of triangulation system, The thing that I like is the wires. It's not just a rounded wires. It's actually also in the triangle where there is quite a sharp, I mean, relatively sharp edge to it where it can actually crack the calcium plug. These are the sizes already mentioned just now. So the other potential advantage positioning. So when you put the balloon, because sometimes, especially in AVF, it tend to slip, and you really have to tug your balloon so that it won't slip. So with this scoring balloon, it tend to stay a bit better and reduce this watermelon seeding effect. Okay. And also, as mentioned, I mean, in the Q&A just now, in the discussion, it's actually quite flexible and also track very well in a tortuous vessel. So it is very useful, I mean, compared to a cutting balloon. Okay, so this is how it looks like when cut. And comparatively, I think this has been mentioned by the product, engineer just now. And also, I mean, the inflation is actually lesser compared to other boba. And if you want to go higher up to 20, you also can do it. And the profile of the Tri-Wedge, I mean, if you want to insert it, it's less traumatic to the vessel as well, especially if you want to slide through heavily stenotic and calcified lesion. And as I mentioned just now, it's actually quite bendable. Right, I think I just skip this. It's been mentioned before. The other thing that I want to highlight, because some of the balloon, like for example, Tri-Wedge, when they are not inflated, the metal is exposed. But in this Tri-Wedge balloon, the metal is not exposed. As you can see here, when the vessel is not fully inflated, or is not inflated at all, it's actually protected by the balloon. Okay, so just comparative table. So more or less the size of the balloon is more or less the same compared to the others, and is compatible to the 018 system, and some also compatible to 025. Okay. So this is just a rated burst mentioned just now. Then I just skip all this. Okay, move on. So the other thing is the operation instruction. So you really have to be very slow when you inflate the balloon, because the balloon that actually cover the metal. So when you balloon it slowly, you don't want to crank it up too fast, because it can actually, when you inflate, you can actually cut the balloon material and then cause the balloon to rupture. And then you want the cutting, or sorry, the scoring method properties to actually slowly cut the what do you call it? The plug, especially in the peripheral system. So that's one of the tips and tricks. So you have to inflate it slowly. But having said that, it can also increase your operating time. So there have to be a balance each time. Okay, so I just want to share some of my cases. I mean, just 2 cases. Okay, the first case is a 51 years old female, diabetic, hypertensive, and stationary failure. So you can expect that the vessel is heavily calcified. So he had a previous ray amputation done before, and now came in with a poor healing ulcer in the first and third toe. So ABSI is poor with a poor Doppler signal. So this is the angio run. As you can see, antegrade puncture, 6 French sheath put in, and there's multiple stenosis along the distal SFA, and also the popliteal area, as you can see here. And then the tarification, there's also the stenosis in the proximal at the TP trunk. The tibial vessel looks fairly okay. And the runoff to the foot, as you can see, I mean, there's we managed to pass our wire quite, easily with the 018 system wire. This is, I think was P18. So we just used the, if I'm not mistaken, this was 5 by 60 Tri-Wedge. So we just start the ballooning, start from the distal, the popliteal, and then just balloon backwards. As you can see, the inflation was, the balloon effacement is quite good. So we just carry on ballooning up. And then this is the angiogram. There's no dissection, as you can see here, with a good, there's still some residual stenosis there, and then we just balloon it again. And then after that, we put a DCB. It's 5 by 150. No, this one is electronics. So, and this is a final angiogram. And as you can see, it's quite good flow. And then this is the distal flow to the foot. I mean, we just did just a standard POBA for the TP trunk and also the proximal anterior tibial. And as you can see, the flow is quite good to the foot. So the outcome for the patient, I think, within the clinic, still strong TPA pulse, good ABSI, and then we still have to do first and fourth toe amputation, and then eventually the wound healed, and patient was discharged with a good antiplatelet therapy. And then the second case, this second case a bit more complicated. It was done by my colleague, also 63 years old, female. Diabetic hypertensive AF on rivaroxaban and digoxin, came in with a history of left anterior shield ulcer for 1 month, and heel ulcer actually. So also associated with breast pain. There's an ulcer there, and then of course the ABSI is used. So this is the CT scan. So as you can see, I think there is some classification, and then there is at this stage, I think there was some element of thrombosis there, but I think it was not really picked up during the pre-operative period. So my colleague actually went in and then did the angiogram, and then as you can see here, there is a filling defect. Unfortunately, he decided to just dilate it with so just to complete the run. So distally was okay, not too bad. So in this patient, I think it was done scoring balloon using a Tri-Wedge from the SFA all the way up. But like I mentioned just now, unfortunately, I don't think this is an appropriate thing to do. Even though there is some element of classification, but because there's thrombosis there, so as you can see, the flow is not good, and there's still a reconstitution. So at this point, I think we decided to actually prolong balloon and also use a longer balloon. So I think the aim of this is actually to plaster probably the thrombus to the sidewall, and also putting when I did this case, I think eventually they have put in a stent. So this is how it looks like. Unfortunately, it's not a good angiogram, as I think some of the clot has probably showered down after the beginning. So the stent was inserted, to trap some of the residual thrombus and then post dilate. So there's still residual clot there. So at this stage, it was discussed with me. I think the plan, so I came in and actually did the aspiration thrombectomy. Where was it? So sorry, this was just okay. So at this stage, I think we because of the cost issue, we use a long shift, fortress shift, and then did some aspiration thrombectomy, and then after that, we leave it. There is some, I mean, improvement of the flow within the vessel, and there is still some residual thrombus. We thought that maybe we can just leave a catheter for thrombolysis overnight, and then this is the completion angiogram. After 24 hours, as you can see, the flow is quite good with no residual thrombus. Acute on chronic ischemia. So eventually, the patient was discharged well with aspirin and rivaroxaban, and the wound actually healed, and the DPA is actually we managed to get a 2+. Okay, so that's for my lower limb. In fact, just to mention that we are also currently conducting a Tri-Wedge AVF study in my center. Basically, it's a randomized controlled trial, open label, to compare the scoring balloon versus plain balloon in the stenotic dialysis access. So our target is basically about 64 patients with 32 patients in each arm. So we have started this study since February 2022, and we are looking at the outcome measure of residual stenosis, complication, and also the latency and clinical success. So far what we have found, I mean, this is the Tri-Wedge group. So we have about 19 patients. I mean, most of them are female. I think this is just a demographic data. So as you can see here, there's multiple location of most of them actually BCF and then have multiple lesions. Unfortunately, I don't. Which we proudly say that the Tri-Wedge can actually boost to the juxta anastomosis and then get into the proximal artery without any problem. Lesion length is more than 4 centimeters most of the time. So far, clinical success is quite good, about 17 out of the 19. Only one minor complication, which is the dissection. Okay, and as I mentioned just now, unfortunately, I think we saw there's 2 patients actually the Tri-Wedge unable to fully efface. Then we actually have to use ultra high pressure balloon. So hence that's why I asked Robert about this issue. So I think as a conclusion, for my setting, I think scoring balloon plays an important role because of the cost. And also try not to leave anything behind because I have major headache, and also it's actually scoring balloon provide an alternative solution to high pressure or ultra high pressure balloon in AVF fistula maintenance. So I think with that, thank you, and I would like to invite everyone to attend our soon KL Vascular Access Conference in 2022. Thank you very much.
Yeah. Thank you, Dr. Hariz, and it's brilliant. And any more questions from our audience? You can feel free to ask our experts. Dr. Robert, would you like to add some comments or questions to discuss?
I think that my colleague covered everything pretty good. I'm not doing peripheral arterial disease since a couple of years already, so I'm not working in that region. But it is interesting to see the results of his study in AV fistula. So I will be really happy to see how it works out with longer term outcomes.
Okay.
But he confirms that it works pretty good in his hands also.
Okay, and thank you. And when we get the reports, and we will share and to all the experts and audience. Okay.